Intravenous hypnotics, such as the widely used drug Propofol, are highly effective clinical tools designed for rapid-onset anesthetic induction. This chart maps plasma concentration over time. When a physician uses manual bolus dosing to maintain that anesthesia, it creates a dangerous pharmacokinetic rollercoaster, aggressive, toxic peaks followed by subtherapeutic troughs. These sharp drop-offs occur because the drug does not stay in the bloodstream. It undergoes rapid, unpredictable redistribution from the central plasma into the surrounding peripheral tissues. Safely maintaining a steady concentration requires an operator to adjust for these shifting distribution rates every few seconds, a frequency of calculation that exceeds human capability. Target Controlled Infusion systems operate as continuous, real-time pharmacokinetic simulations of the patient. Look at how the delivery changes. The erratic spikes of a manual delivery are corrected into a flawless, steady-state concentration. By deconstructing the algorithms driving this system, specifically a single mathematical constant known as Ke0, we can map exactly how the machine targets the brain. Once we understand how to lock in that precise target, we can observe the neurobiological reality of how the anesthetized cortex actually processes external stimuli. To the microprocessor, human anatomy is a three-compartment model. It begins with V1, the central blood plasma where the drug is injected. The drug then bleeds into peripheral compartments. V2 represents vascular tissues like muscle, while V3 represents slower, vessel-poor tissues like fat. Drug transfer between these tissues is governed by specific rate constants. You can track bidirectional flow using the variables K12, K21, K13, and K31. Simultaneously, the drug leaves the system via elimination and metabolism, tracked using the clearance constant K10. To achieve a steady state in the patient, the TCI microprocessor must continuously solve for all of these moving variables simultaneously, recalculating the infusion rate every 10 seconds. Looking at this closed-loop feedback schematic, the inner control loop constantly compares its internal simulation against the physician's target. To hit a new target, it executes the bolus, elimination, and transfer scheme. Step 1. Administer an immediate bolus to fill the central V1 volume. Next, the pump manages elimination and transfer. It superimposes two exponentially decreasing infusions to match the drug lost to tissue distribution and adds a third constant infusion to offset liver clearance. We can validate the mathematical accuracy of this process clinically. This table shows the median performance error rates for various Propofol models, which all fall within the safe limits required for automated delivery. But there is a critical flaw in this baseline approach. Targeting the central compartment achieves mathematical perfection in the blood, but it causes a severe delay in the actual clinical effect on the patient. Blood plasma is merely the transport mechanism. It is not the site of hypnotic action. To close the gap between plasma peak and clinical onset, pharmacologists mapped a theoretical fourth compartment, the effect site, representing the brain. The mathematical link bridging blood plasma to the effect site is the rate constant Ke0. It dictates the time to peak effect. By utilizing Ke0, the pump calculates a highly aggressive solution. It initiates an intentional, temporary plasma overshoot in V1, forcing the drug into the brain as quickly as possible. Once the fourth compartment reaches internal stabilization, the plasma level is allowed to immediately decay. This modification allows the algorithm to safely weaponize a temporary plasma overdose. It achieves the required brain state instantly, without triggering the severe hemodynamic collapse a manual overdose would cause. The exact numerical value assigned to K0 dictates how aggressively the pump will drive that initial plasma overshoot. In clinical practice, the Marsh model for Propofol relies on body weight parameters and assumes a generally slower K0 transfer rate. The alternative Schneider model incorporates age and lean body mass and utilizes a faster K0 rate constant. Because the Schneider model anticipates a faster transfer of the drug to the brain, it utilizes lower peak blood concentrations during the overshoot. This provides critical protection for elderly or frail patients who simply cannot tolerate steep drops in blood pressure. Selecting a pharmacokinetic model is a clinical decision about the exact velocity and aggression of the patient's induction. Let's look at the biological reality of that fourth compartment. What actually happens when the drug hits the cortex? There's a widespread clinical misconception that general anesthesia simply switches off or silences the auditory cortex. Neuroscientists at the Pasteur Institute recently utilized multiphoton microscopy to physically track the activity of nearly 1,000 individual cortical neurons in real time. This visual maps their data on the awake state. When a healthy patient hears a sound, specific dedicated neuron assemblies fire distinctly in response to the audio waveform. Conscious perception of that sound relies entirely on the contrast between this organized, evoked firing and a relatively quiet background state in the brain. The researchers utilized an imaging method known as frequeness to analyze the brain under TCI anesthesia. They observed that the auditory cortex still fires when stimulated by an external sound, but the baseline environment has completely changed. Under Propofol, the brain's spontaneous activity ramps up, creating a constant storm of randomized neural noise. When the audio waveform hits the cortex, the evoked response is completely lost in the chaos. In this state of cortical masking, the brain's internal noise effectively overwhelms external sensory signals. The patient becomes unconscious to the sound because the signal-to-noise ratio in the cortex has been entirely destroyed. The TCI algorithm, driven by the Ke0 constant, maintains the human brain in a sustained state of sensory masking. It provides a mathematical link between plasma kinetics and the threshold of conscious perception.